Good afternoon, everyone. We have a very distinguished speaker who has a lot to say, so we want to make sure to give her time. All right. What do you do? The silent. Okay, just wave your hand if you can hear me. Count to three. I didn't pass preschool, I don't think, so I don't know how to. Okay, we're going to get started. I'm Anna Chodos. I'm faculty here in the Division of Geriatrics, and I am thrilled to introduce our incredibly, I would say for many of us, cherished speaker and colleague, Dr. Soo Borson. I think it'd be very hard without taking up all of her time for the talk to summarize her impact on our field, our shared field of geriatrics, and particularly in the world of dementia, but I will try really briefly. Some of it's on her slide. But particularly, she's a faculty at the USC Keck School of Medicine. She's a professor emerita as well at the University of Washington. That's where she started a memory disorders clinic, and where I think many of us will recognize the enormous impact she validated and developed the mini-cog, which is something that I know I use all the time. Very hard to state her impact, summarize her impact on research and dementia care in general. But I think if you take a look, you'll see that she, across public health approaches, primary care approaches, community approaches, has had a really broad impact in the world of dementia care. And so that is how I've been really fortunate to get to know her as a crucial advisor, a touchstone for sanity, for clarity, for our program in dementia care. And we are so grateful. I think I also want to acknowledge she's an incredible mentor to many of us in the room. You have a huge audience also watching, Sue. So many more people are with us. And I think of late also really important is her leadership as a co-lead in the CDC-funded BOLD Center of Excellence for a public health approach to early detection of dementia. I probably botched some of that, but think of how important that is. I think we don't often think of the public health approach around us to dementia. I know today we're going to get a talk that's really going to have us seeing things differently, thinking about things differently, wanting to do things differently. So I'm really looking forward to her talk, and I hope we all have great questions. I know we will. So please come up, Sue. Thank you so much for joining us.
I couldn't have asked for a nicer introduction, because I really do want the way we do things to be different. And I hope I'll convince you about some of the differences that I'd like to see, whether or not they can occur in my lifetime. So my disclosure slide, if you guys get the slides, just look at the disclosures if you're interested in them. The only one I want to mention, well, I do want to mention something. The mini-cog is a well-known tool now. It was very unpopular, especially with neurologists, when I started working on it, because it was thought to have too little information to be of any use. And I was emboldened by a statistical colleague of mine in the Alzheimer's Center back then at the University of Washington, who said short tests have as much or more information than longer tests. And he was trying to get his postdoc to actually develop a paper on that. I don't think the paper ever came out, but I thought, well, that's enough vindication for me, because certainly my colleagues at UW weren't terribly enthusiastic about anything I was doing. And so it was nice to have somebody who thought it could matter. And it has mattered. And over lunch, I heard again something that I encountered frequently in the early days of mini-cog, which is when a clock drawing is abnormal, it often shocks people. It shocks the family. It provides information they didn't have, and you can't explain why it was abnormal, not really, but you can see that it is this very familiar thing. Now, we're going to have a problem, because there is nothing like it. There's nothing like clock drawing in the entire panorama of testing that we do, and that's a shame. But I haven't seen anything. I haven't been able to conceive of anything that would have power of this type, and so we live with it for now. So not known to you is that I've also been working on other tools over a long time, most of which never made it to the serious light of day. But they were all geared toward this idea of how do we shorten our assessments of key elements of dementia care in such a way that we can use them in non-specialist settings. That was the impetus for the mini-cog. The same is true for the stress thermometer. The same is true for a very short, it's called Behave 5+, which is the 5 behaviors plus insomnia that cause clinical attention in dementia. Apathy rarely does, but serious withdrawal and couch potato sitting there like a lump, that does. But, you know, apathy, what's that? Well, that's apathy writ large. So Behave 5+, we've used it. It was validated in a way that was quite different from the conventional way that you think of validating. It wasn't validated against another tool. It was validated against caregivers' reports of services they needed and didn't get in the last year. And so the scoring of the behavioral scale and the stress thermometer were set such that they were associated with unmet need for services. That's a completely different way of thinking about things. I wasn't planning on talking about this today, but and I don't have any slides about it, but it is an example of kind of a different way of going about thinking about assessment. So, and one last thing is the managing your loved one's health tool, which is a caregiver activation tool. It sits like a lump, like an undigested corn pone, waiting for somebody to get excited about it. And now I'm going to launch into my real talk after saying one more thing, which is that what I have to say here today is what I think. It is not necessarily the view of the Centers for Disease Control and Prevention, nor is it the view of any academic institution who might or might not once have employed me. So it's just what I'm thinking about. And with that, and one more statement, which is how incredibly privileged I am to be here with you. I've been saying it all day. I've been feeling it all day. That and to the fellows, I said, I never in a million years would have expected myself with the life I had to be here. And so I'm so grateful to you for inviting me to talk with you. And now onward, let's see if I can actually do my talk. Okay, so why do we need a public health approach to dementia? I like to say that when Josh Chodosh and I were writing the grant to CDC that was ultimately successful, neither one of us had much of a clue about what public health approach to anything was. And so I hope he won't be embarrassed by my saying that in public, but we were really struggling to figure it out. What is it? Well, so why we need it is because people are hurting. That's number one. Number two is because there are such large social and economic costs. And I really emphasize the social and the economic costs that are attached to that social cost. And then thirdly, it's because there's such a huge impact on the population in so many different ways. For a disease that has relatively low prevalence, for heaven's sake, it really is relatively low. Nevertheless, it has an outsized impact. And so we need to be attending to it in a different way. Okay, so I have three objectives. They're not exactly the same as the ones that I submitted, but let's see what they are now. So it's to trace the public health approach to dementia. How did we get here? How did our national strategy come into being? What's the general shape of that strategy? What's BOLD? What is the BOLD Act? What is it all about? And then our early detection center. What are we trying to do here? Because everybody knows that detecting something you don't act on is a useless exercise. So we have much more in mind. Then I want to kind of bring up the three frameworks. You've got two, the 4Ms and the 5Ms, and I've got the 6 domains of health. And I want to introduce you to that idea as really an extension of the same way of thinking about frameworks. And then I want to expand everyone's participation in dementia care transformation. And by everyone, I'm talking to you. I would like to see geriatricians have much more engagement with dementia as kind of a leading edge of geriatric disability. Hardly the only thing, but as a leading edge. Okay, so tracing the public health approach to dementia. What's the scope of public health? Well, first, we got to think that people living with dementia, they're absolutely everywhere. And so are their caregivers. And so dementia, it's us. Dementia are us, after all. And so public health has a scope that looks like this, and you probably can't see too much of it, but it's lots of things. It's like, you can find yourself here, but it's really everywhere. I like to think about business and employers, about what about the impact of dementia in business? Well, we know there's a lot through caregiving, principally. It's through caregivers who can't stay at work, and our policies, our leave policies, which are horribly outdated. But you can see that everywhere that dementia is everywhere that we all live. And given that, what do we do? How are we going to deal with it? And it is clear that we have a workforce problem. Bingo. So of course we know that we don't have enough clinicians and other kind of people who work in the medical environment, including nurses and social workers and people who work at home with patients. And in fact, what we need is a whole lot more direct care workers than we have. It is the most understaffed area of care in the United States. Is we need more unlicensed workers who are trained to do things that they can do and want to do. And my little plug for the recruitment through empathy approach to finding people who are natural caregivers. None of us really know how to do this, how to find the people who are natural caregivers who are gifted at this, but we need to be able to find them because they're the ones we need. Okay, so what is BOLD? It stands for building our largest dementia infrastructure. So it's really boldy, but that would seem silly. So we call it BOLD. Well, BOLD is the product of a law, the BOLD Act of 2018, that was federally empowered the CDC to develop a serious public health infrastructure that would address dementia across 3 domains, and you'll see what they are. So this is dedicated dementia-focused public health infrastructure. We were lucky enough to get one of the initial center awards in 2020, the Early Detection Center. The second round of funding has now funded 43 public health programs around states and counties. And there were 23 in 2020, now there are 43. So you'll see what that looks like. It looks like the 2020, the greens are the BOLD awardees, the states that had BOLD awards. And the California award, I mean, there was an LA County award, it's pretty great. I worked on that one too, that was really fun. And in 2023, look at all those green states and territories. There's a lot of action going on. So what are the BOLD centers? That's where I sit. I sit in a BOLD center. There are 3. Early detection of dementia, that's me and Josh Chodosh, whom you know, with a mission of increasing early detection of dementia and awareness of dementia in communities. The second is the Risk Reduction Center, and that's housed at the Alzheimer's Association. And then the third is the Caregiving Center, which is at University of Michigan with a social gerontologist, Joe Gogler, in charge. So what do we do in these centers? Well, we interact with health systems, community-based organizations, departments of health in varying arrays to do these things, to enhance provider messaging, normalize cognitive assessment as part of routine care. You all know that this has been my mission for a long time. That's at the health system side. On the community-based side, to drive community action toward dementia, and on the Department of Health side to, I can't even read it, expand what data systems and commitment of dollars from states, largely from states, to programs that address dementia. California has a BOLD award in this round. In the 2023 round, California as a state has a BOLD award, but has not yet released its plan for public consumption. So this is us. This is Josh and I are co-leads. This is our team. Nothing, just letting you know that they're all here with us today. And here is what we like to talk about. Our mission is to make early detection of dementia routine across the United States. It's a very simple mission. The second is to discover and co-create solutions with stakeholder organizations and communities so that this can happen and that it matters to people, that something follows it. And the third is to promote early detection through effective public health, clinical, and community initiatives. Anti-stigma is a really good goal, and yet, you know, we could spend an hour on stigma, and we don't have time for that. It's a good conversation to have. I have a point of view about stigma that I think is a little bit different from most views, but that's not for right now. And then we want to empower individuals and stakeholder groups to create their own pathways from detection to evidence-based care. So how we do this is we have to be building bridges, and that is what we do. I'm going to give you an example of what might be the very first public health approach to detecting dementia in the United States. Well, first, this is our partners. This is everything in blue is the groups, the states we've already worked with, and then we're kind of building alliances with others, and those alliances take different forms depending on what their needs are and what we can offer to them. So this I call an early innovator spotlight. This was, to my knowledge, the very first public health approach to dementia detection. So Kristen Felton, she was the pioneer in 2015 who decided that it'd be really easy to give people mini-cogs. And she understood, we talked about it, and I'd already done the work showing that medical assistants with 10 minutes of training can reliably give the mini-cog as long as they're held to accounts, and you know they have to do it. And that's what the holding to accounts was. They needed supervision to turn in their forms, paper form then. So, but they could do it perfectly reliably. There was no problem with medical assistant giving the tool. So she thought, well, why not community workers, you know, unlicensed workers? And she created a role, the dementia care specialist, who is this is one of the care navigator types of roles, unlicensed people who learned to do a job and work for the Department of Public Health. So they were trained in the mini-cog. And for those who couldn't draw clocks because they were completely non-literate from the beginning, they could get animal naming as an alternative if there was concern about the problem with clock drawing and literacy. So that was the beginning of Kristen's program, the creation of the dementia care specialist role in Wisconsin, and followed by building dementia-friendly communities and developing other resources like Memory Cafe, another really cool thing to do, which I've had some involvement with in 2 states. And now they have 70 dementia care specialists working across the entire state. So one of the cool things about this was as it evolved, it became, I think I forgot to say that it's now payment for dementia care specialists is a line item in the state budget of Wisconsin. Now that isn't entirely thanks to Kristen and the Department of Public Health. This has a lot to do with Sanjay Astana and the Wisconsin Alzheimer group and Amy Kind and the focus of that Alzheimer group on community outreach and making serious research happen in a community setting. But so what happened, well, I want to kind of skip over some of this. This is what the dementia care specialists do. They train AAA staff basically to do screening, to think about dementia, to use their observational abilities to detect dementia in addition to being able to give screens. They build coalitions in the community, so standard public health work. They provide support for individuals and families. But what they do also is they connect people to the Wisconsin, the Wisconsin Alzheimer Institute Clinic Network, which is about 40 clinics in Wisconsin that all use a common assessment procedure, all driven through the ADRC group, the Geriatrics and ADRC group at the university. These clinics are autonomous clinics. They are not run by anybody. They just live inside the health system where they were founded. Any health system could have one if there was a champion who wanted to set one up and was able to collect enough clinicians to do a kind of, they like to think of it as a state-of-the-art evaluation for people with cognitive impairment. And the docs who run these, they're all docs. They can be in any of the disciplines that deal with older adults with dementia: family medicine, internal medicine, geriatrics, and geri psych. So the public health initiative helped to build the clinical initiatives that resulted in 40 clinics, and now they have a connection with each other. So the public health program refers to the clinics. The clinics, unfortunately, don't often communicate back, and that's a common problem that we've all encountered who tried to do this bridging work. But it's a start, and I think it's a model. I wanted to share it with you because it was the first example of using non-clinical people to address a population prevalence problem. And it's interesting in that way. Georgia has developed this to a high art. Georgia is perhaps now among, up there with Wisconsin. There are a few other states that have really made immense strides in this way. But Georgia's doing the same thing, except they have far fewer clinics. But they have clinics that are supported by the state, as does California. And they're growing each year. So the role that Kristen Felton developed, the dementia care specialist doing screening, is now we now think of this person as a dementia care navigator when we think about the guide model, the special payment model for managing people with Alzheimer's disease in healthcare settings. Unlicensed people who will do a lot like Care Ecosystem. I mean, really, it's modeled after Care Ecosystem and some of the other care management programs. I think the original care management program was started by a neurologist way back in the early, late 20 somethings, Barbara Vickery. And then it morphed through Chris Callahan and Malaz Bustani and David Rubin, and Kate's model is uniquely well suited to define kind of the roles that this person will have in the new experimental payment model for dementia. Okay. Now, dementia as it appears in frameworks for healthcare for older people. This is where my passion has really been ignited most recently. So I want to start with this is a rubric that we developed for the Bold Center on Early Detection, and that is that dementia is a manageable chronic condition. It's a chronic disease. It's not like all other chronic diseases, but it's a chronic disease that has in common certain features of all chronic conditions. It's progressive. People do worse over time. And I don't know of a chronic disease condition that doesn't worsen, and that doesn't follow the same rule as dementia does, which is the worse it gets, the faster it gets worse. Right? True for COPD, true for heart failure, true for kidney failure. It's how it happens. So these are the things that we consider to be crucial to managing dementia as a manageable chronic condition. We have to detect early before a crisis, and the crisis theme you're going to hear more about. We have to center relationship, because relationship between a clinician, a patient, and a family is the solid ground on which care happens. And without it, no care can be very good. So it is the foundation of effective care, and it's something that physicians tend to forget about. They tend to undervalue their own role as, dare I say, healers, whose goodwill and skill are the crucial elements in both retaining their patient and doing a good job for them, being able to hear what patients need. So I'm reminded of a study that showed that if doctors are asked, what's the most important thing about your medical practice? Oh, it's the skills that I have. It's the knowledge and skills that I bring. You ask the patients and they say, it's compassion. And not everybody in this room is a stranger to such ideas. I'm aware of that. I just want to call them out. So detect it early, center relationship, and address complexity, because after all, it is the reality of dementia for most people. Yes, there are a few people, a small percentage of people with dementia who who don't have much else going on, but the ones who have a lot else going on is the one I want to focus on. So, so if we're dealing with complexity, then we're also enjoined really, I mean, we must manage risks and we have to think about what are the risks of crisis that occur in dementia? What is a crisis in dementia? You know, how do we think about a crisis? But if we were to think about the potential of no crisis care, what might that look like? Well, let's look at what we are doing actually. This is a newly published paper in JAGS from Julie Zissimopoulos' Dementia Economics Group, research group, that shows these peaks are at the point of diagnosis. So the 0 mark is where a dementia diagnosis appears in the medical record. Boom. Okay. So look at the size of those peaks for hospitalizations and for outpatient visits. So these graphs go back 12 months before the diagnosis first appears in Medicare data and extends 12 months out after the diagnosis. And all these are, this comes from 100% Medicare sample. That includes the best available Medicare Advantage data. This is why we have 2 graphs on each one, a blue one and a red one. The blue one is traditional Medicare fee-for-service. The red one is Medicare Advantage. And the authors of this paper really emphasize that there's less utilization in the Medicare Advantage population. I use it to say, well, wait a minute, what's going on here? We're diagnosing in the midst of crisis, aren't we? We're not diagnosing before a crisis. This is right when there is a crisis. All right. And so this is a study we did at Kaiser Southern California. I wasn't able to very well design my additional boxes, but I want to kind of walk you through a couple of points here. This Kaiser, as you know, integrated health system. It's Medicare Advantage for senior care. And what did we learn? We wanted to know where were first diagnoses occurring in Kaiser Southern Cal. Was it in primary care? Was it in specialty care? Was it in outpatient care at all? Was it in inpatient care? Nothing about nursing home, nothing about any other form of long-term care or special care programs, but just, you know, outpatient and inpatient. So somewhat shy of 50%, but fairly close, of these diagnoses were made in the hospital. Okay. The shocker was that those diagnoses were over 90% of them were being made by coders. They were not being made by clinicians. And as codable, billable diagnoses, they never appeared in the problem list. There's no clinical record of those diagnoses. Right. Well, the first author of this paper is a Kaiser employee, and I would have said things that are not okay to say in print, but I knew that it would be sensitive, and so I didn't want to get her in any trouble because I am seeking revolution. So there are some interesting findings here. I mean, one of them is that, you know, primary care docs make diagnoses of dementia NOS. Well, we've known that, but here it is again. It's still true that geriatricians make more specific diagnoses than primary care docs do. That those few people who get to neurologists or psychiatrists get more specific diagnoses. And what was the last? Oh, yeah, all clinic, right. And then the hospital diagnosed, they're, you know, can see that a lot better than I can. So most of it is unspecified dementia. Okay, that isn't anything in itself other than it's just describing a pattern of who's thinking about how to think about what the dementia is. So how many people had any kind of cognitive assessment? Well, somewhere around 15% total. Many more in geriatrics, more in the specialty services. To be honest, I don't know how any cognitive assessment quite appears in the hospital diagnosed group, but it does. And how bad is the dementia when it's diagnosed based on the scores that we were able to find in the record? And these were not searchable fields. This was a labor of love to find these scores embedded in notes. And so on average, the MoCA score was was about 15, 16, 15, 15. I don't know how there were any 12s in the hospital, but there they were. And so at the MoCA score of 15 is really comparable. It looks like, they're pretty much the same no matter what test was used. It's at this, when testing was used, it was detecting dementia at that transition point between mild and moderate. Now, that's exactly the people who came to the memory clinic at University of Washington. It's people who, it was a while after symptoms had begun, but by now the family has put it all together. There's a pattern here. It's not just a little car accident. It's not just forgetting the shopping list. This is something more. So the consolidation of a pattern within the family to recognize dementia tends to occur at about that point. And that's also the point where the amount of help that families need to give somebody with cognitive impairment begins to be seriously felt. That is the underlying reason why dementia, when it is diagnosed with a tool, shows up at this stage. And that's hidden. It's not, we didn't find this in the data. That's just how it clinically shakes out. The other thing I want to point out is just how sick these people are. The Elix-Hauser comorbidity index is quite high, in the range of 7. I'll also mention that as it happens, the patients diagnosed in hospital had a much higher mortality rate in the 6 months following their first diagnosis than others. So when we look at this, we're seeing it's clearly not early detection by any stretch. And if we want to think about what early detection would be good for, we have to have some idea of what the goals of care are. And I would say, you see there, it depends on who you ask, because the answers are everywhere. And if you ask for the goals of dementia care from a patient, no idea. Family, not much more of an idea. Primary care doc, we're going to find out. Alyssa Seidman is about to start a study to ask them about this, about what they value and what goals they have for patients. I'm really excited about that study because I don't think anybody's asked it before in primary care. The specialists already have a preformed idea of what their goals are that's driven entirely by their professional specialty. But for primary care, I don't think we know very much at all. I want to propose that we all can agree on a goal, and the goal is no crisis. That's the goal of care for dementia, no crisis. It supersedes, it doesn't exclude any other kinds of goal, but it's a genuine healthcare goal, unlike a brain treatment goal. So this is a whole person idea. How do we prevent crises in dementia? Because every crisis carries the potential of never getting back to the way it was before. And to say nothing, the terrible stresses on people of going through crises, especially those that we suspect could be partially or completely prevented. So can we all agree that no crisis care could be a goal? And if so, then how would we even think about doing it? So for designing no crisis care, this is what I think we need. Detect and diagnose early, okay? Activate patients, family, and clinicians. Establish a cadence for contact. And this is something I want to stress because we have no idea how to think about cadence in clinical care. People say, well, how often should you see a patient with dementia? I don't know. When they need to be seen. Well, they can't be seen when they need to be seen because you don't have any appointments. And so how do you how do you think ahead about, well, what is a cadence? We published a little paper many years ago, a resident and fellow and I, about this, and we just boldly said, it depends on the stage, and here's how often you should see the patient, all things being equal. It was totally, made up out of our heads, but it was also what I did in the clinic, so it was probably about right. Okay. So there's the cadence piece, and then there's prevent and intervene early in acute or worsening chronic illness. Ooh, now we're starting to get serious, right? Because, and I was asking Michael Steinman on the way to lunch about, how do you keep somebody with heart failure out of the hospital? And we care about heart failure, well, because it's bad. It's horribly disabling when it's bad, and because it's such a common cause of hospitalization in older adults and older adults with dementia. It's probably the leading cause of hospitalization, up there with, I mean, there are others, but it's really important. So how would you prevent exacerbations or hospitalizations for exacerbation of heart failure? I'm not going to tell you yet. And I'm not going to tell you at all, but I want you to start to think about how you would really practically do it. I do have a scheme for it. I'll tell you what the scheme is, and it's not just about heart failure. There's only 3 ways to prevent hospitalization, period. You have to prevent the thing that might lead to it, just prevent it. UTI is a great example. You can probably prevent most UTIs in people with dementia who are not bedbound, okay? But you have to do things that people don't know to do. You have to detect it so early that you can fix it before it gets so bad. That's also really hard to do because people get bad so fast. Old people get bad so fast. And they get so bad so fast. And then the third way to prevent hospitalization is to make a decision there won't be any more. There is no need. This is a hard sell for everybody. It seems like an ethical violation. We won't get into that in any detail, but those are the 3 ways you prevent hospitalization. It's important to know what they are, because if you want to set out to try to do it, then you have to be able to implement some sort of a plan. Okay, so what else? Well, yes, we want to use safer, more effective, and fewer usually medications. We want to keep patients and families happier, and by that I mean happy. I don't mean something soft and squishy. I mean joyful. I mean creating opportunities for joy and counseling people that's what they need to be doing. They need to be creating opportunities for happiness, something that many of us have to do on a regular basis anyway, because it's easy to get stuck in not being happy. Okay. So reduce injury risk. Okay, sure. These are no-brainers. Prioritize continuity and tailor your contact. That's the cadence piece. Then prevent mood and behavior problems. This is in its infancy. We can treat some of this, but we would probably do better if we tried to take a preventive approach to behavior management. And I'm not prepared to assert numbers around that or even really a path, except that all the rest of this is helpful, especially the happiness piece, the creating opportunities for joy. Organize shared care, okay. Integrate social and clinical care, no brainer. I mean, we all know that. We can't do it very well, but we know about it. Okay, well, what are the facts? I still love this slide. This is a very old slide that we put together way back and published in the chapter I wrote with Josh. About the rising prevalence of dementia in the red line, the number of geriatricians from 1992 to 2030 in the purple broken line, the number of geriatric psychiatrists in the bottom line. And the shocking thing is that these data are very, very old, but they hit it exactly right in terms of where we are with geriatricians. I think they got it right with Geri Psych too. I mean, when you look at the numbers for Geri Psych, there were, a lot of people got certified and I was one of them, but why would I recertify for all that money? Was I going to learn any more by recertifying? No. So I'm not certified, haven't been for a long time. And that's been true for a lot of people who did once get certified in the early cohorts. So this drives us back to primary care, doesn't it? Where it's the only, I think it was Barbara Starfield who said that it was the only medical discipline that can improve population health. And how? By surveillance and problem detection, by management of chronic conditions, by preventive interventions, and by treatment of acute illness. Those are the ways. These are the standards on which primary care especially family medicine, was founded. This is what primary care is about. So we need to support primary care. What do we know about them? That they make 85% of first diagnoses and provide 80% of the care of people with dementia. Those rates are late, low, inequitable, and non-specific. That they have no dementia care model. There is no dementia care model for primary care as it exists today. And there's an inadequate support from the system to create such models and enact them. And finally, who is better suited, a quote from one of Alyssa Seidman's informants, who is better suited than us to do this work? I agree. How about memory disorder specialists? Well, 15% of first diagnoses, less than 10% of care, diagnosed and adios. We've all heard the phrase. Long waits, unequal access, consult model. See them once or twice. Tell somebody else to do something, right? That's what we do. Disease focus rather than person focus, and variable relationships with primary care at the system level. So those, we all know about the problem of specialist numbers, and we are less thoughtful or public about the limitations of specialty models for whole person care. So I like to be very clear about that most specialty models are not whole person models. So then these are the problems that we need to fix. None of this is anything other than hand waving, really, and so I don't want to linger on it. We've got a lot of problems. You can see them, you know them already, but they have to be here in order to set the stage for how do we think about fixing things. Okay, what's happening? I don't know. Okay. So this is a study I'm really proud of. This study was my idea to look at Kaiser Permanente hospitalizations in dementia in the ACT study, which, as some of you know, is a research quality diagnostic evaluation in a population framework that Eric Larson started some 30 years ago now, I think. But the idea was to find incident cases of dementia out of a population of cognitively normal seniors. And that's what he did. He was looking for incidents, looking to study incidents of dementia. And so it was very much a state-of-the-art assessment when it began, and it's improved or become a little more detailed since. But so this is the sample that we used for this. People who had a new dementia diagnosis versus people who never got a dementia diagnosis during the period of follow-up, which for the dementia group was 9.6 years, for the no dementia group was an average of 8 years. Long time follow-up. So 86% of the people with an incident dementia diagnosis had a hospitalization. 40% of them had a preventable admission based on standardized criteria. For those who had no dementia at any point, the rate of preventable hospitalizations was about 17%. We will and should and can quibble about what's preventable in late life dementia-related hospitalizations. I understand that simple language doesn't address the complexity of the issue, but this was, I think, an important finding because it was very rigorously done. The thing that was different about it was the research quality diagnoses in a population. So that's one of the great legacies of Eric Larson's work, I think, is creating this data set that has been so richly used for new discovery. Okay, so why do we care about hospitalizations? The major reason is because everybody cares about them. They're bad. You know, they feel bad. It's not nice to be in a hospital. If you've ever been in one as a patient, as an adult, it's not a nice experience. Probably pretty much no matter what you're getting treated for, there are so many things that are not nice about being in a hospital. So people don't like it if they don't have to be there, mostly. But health systems use it as a metric. And so if hospitalization is going to be a metric because it drives total cost of care, then at least we should be thinking about hospitalization rates as a target. This was a systematic review and meta-analysis of studies of hospitalization rates and predictors in dementia that was done in the UK. The studies were from anywhere. I show you the numbers, the graph over there, because not because you can read it, but because I thought it was really pretty and would kind of break up the monotony of a word slide and my voice droning on. So the rate in dementia was 0.37 to 1.26 admissions per person per year. It varied across that value. The relative risk was 1.42 for dementia across all these studies. It was 1.40 in the ACT study that we did in Seattle. So I think that was a nice correspondence. Dementia severity itself was not a predictor. What was a predictor, of course, was age, multimorbidity, polypharmacy, and functional disability. Those were the predictors. Okay. Since then, a student and I have been looking into the more recent literature to see, well, is there something new that wasn't covered in this review? And I'll draw your attention, though, to one feature of this, which is if I don't think you can read it, but in the graph on the left-hand side are categories. These are categories that you're going to meet again when I talk to you about domains of health. They're not exactly the domains of health that I'm talking about, but they're very close. And those domains emerged from the data as ways of categorizing what was being measured in any particular study, what variables were being measured. All right. Okay, so one of the things that was new since the publication of that paper in 2019 is these papers that talk about continuity of care. In the US, Halima Amjad and Julie Bynum did a study showing that high continuity of care was associated with fewer hospitalizations, right? With standardized means of looking at continuity of care in the Medicare database. ED visits were also high continuity of care affected frequency of ED visits. So both ED visits and hospitalizations were affected. Cost of care was somewhat less with high continuity of care. A Canadian study, which I was very delighted to find in 2021, is this one by Godard Sebiat. This is from a primary care research group that looked at, again, large numbers of people. They looked at continuity of care slightly differently. Their system is different. Primary care is team-based to a greater degree than it is in the US. So perhaps more potential to prevent hospitalizations, but what they could measure was continuity. And they found, like Halima and Julie, that high continuity reduced the risk of hospitalization and ACSC, potentially preventable admissions, and ED visits. So to prevent one ED visit in Canada, you had to provide continuity of care for 29 patients. That's a pretty good return on investment. You had to treat 118 with high continuity to prevent one potentially preventable admission, and 97 for all-cause hospitalization. Okay. So to me, this all adds up to there's some new roles for geriatricians that I really want to see come into being, and they're not unknown to you, but I want you to think about them with me. I say we need big picture expertise, and I look at you as having big picture expertise. This is what you are good at, is kind of seeing the big picture, even if you work in a small area. So there are kind of the big things that you do if you get to be a leader in a healthcare system. You got to make the case, right? That developing a dementia care pathway, developing a detection paradigm and acting on it, that matters. You have to find the opportunities where it can matter. Then if you're a healthcare decider, you have to figure out how to stratify who you're going to apply this to, because it can't be everybody probably. And then you have to figure out how much it's worth and whether that, whether it translates into financial value or moral value or a combination of the both or other. And then inside these plans, we've got signal detection tools, quasi-diagnostic measures, and diagnosis and care protocols that can all be hugely contributed to by geriatricians who work in those specific areas of research and practice. So from a leadership point of view at the outside to an enactment point of view on the inside, we need tools. And picking the right tools is a job for experts, right? You would not use a screwdriver to hammer in a nail, duh. So we have a lot of tools in our toolbox, but we have to decide which ones we want to use and for what purpose. So we have tools for detecting signals. And they look like this. I mean, we have risk estimators, and you're all familiar with eRadar. You're not familiar with CI Wizard, which is another kind of risk stratifier coming out of Minnesota that hasn't yet really seen the light of day quite yet. But they use AI algorithms for risk and associated factors, right? Then you got self-assessment tools, and there are a few of those. And then objective tools, such as brief, robust screeners. They are signal detectors. They're just detecting a signal of possible cognitive impairment, which is what I would argue we need to be doing. That's what we're really after. We're not after screening people to get a diagnosis today. And then you can use care delivery data, as we know, because there are correlates of dementia diagnosis and healthcare utilization that can be used as signal detection devices and population stratifiers. Okay. And then we have tools. Those are tools for doing those jobs. Now we have tools for organizing care. We've got the 4 M's to geriatricize the general medical environment. Fantastic. We have the 5 M's that differentiate geriatricians from all other practitioners, right? They do the 4 M's and they do multi-complexity. And then we have my favorite model, because it's mine, and that's the 6 domains of health. I'm sorry. I mean, yeah, it just is what it is. It's like the distillation of, if I thought I did a pretty good job taking care of dementia patients, what was it that I did? Well, that is what I did. I put a care plan at the center, and the care plan had the patient and the family and whoever else needed to be involved. But it also addressed all these different layers of which are what I call the 6 domains. And they start with the brain, because we're starting with dementia. We can go around the domains. They are, there's cognition, there's mood and behavior, there's medical, which is by far the biggest because it encompasses comorbidities and various physical risks, like fall risk, functional risks and so forth. Everything that you deal with mostly fits in that medical domain. And then we have the caregiver domain, and then we have social, health-related social needs, and then we have the care environment. How is the care environment organized for this person, be it the formal care environment in healthcare or long-term care or the home care environment? It's still environment. These are the 6 domains of health that I worked with that I thought contributed to the benefit of patients that I cared for. All of them happen to be supported, except the care environment and the caregiver domain were not terribly well supported in the UK systematic review and meta-analysis. All they looked at for care environment was participation in some kind of specialty clinic, and that didn't have any effect on hospitalization. They didn't look more broadly. It was just that. The caregiver data at the time was very weak. It's still not very strong, but so those 2 domains didn't work. In the cognitive domain, that review found that non-Alzheimer dementias were more likely to be associated with hospitalization, Lewy body vascular. Understood. So what I was doing all along in a clinic somehow got validated in a systematic review published in 2019. And I thought, well, that's really interesting because everything I did was started with induction, working as a doctor with a suffering person and their family. And along the way, trying to pile some new data into this to see, well, what are the data saying? But it was really an inductive idea to start with. It came purely out of clinical medicine and the operation of clinical medicine at the beginning, that now it does have good, strong support. The model itself does not have support. And so, oh, and I do have this slide. I mean, there's a lot in that 6-part model that I am not talking about, level 1, level 2, level 3. Maybe I can talk about that at some other point at dinner or something, if anyone's interested. What does that mean? These are the domains, end of story. I don't want to dwell on it. Our time is running short. But how would we use it? And this, to me, I know it's late. I'd like to say we might have started a little bit late, because if we did, then I'm going to take a few more minutes. Is that okay? Okay. So I wanted to see, what can we do with this idea? Can we measure the domains in a simple way? And what does it look like? Can we use this domain-based model to describe patients? Well, yeah, we can. And here's what they look like. These were 88 people who were recently discharged from a hospital, found because they had a dementia diagnosis, an unplanned admission, and at least one other comorbid condition, right? Since dementia is not a reason to be in a hospital. So we were looking for chronic conditions. We found a very multi-morbid, very old group, just as you'd expect. They had all kinds of mental status changes. They had significant functional disability. They had high Charlson scores. And among the interesting findings was that at the point of discharge, there was virtually no care plan that involved caregivers. There was no training of caregivers at all. There was no discussion of the reason for hospitalization for the patient, or how to care for this problem after the fact. And the net effect was that caregivers missed a few important details, like a diagnosis of heart failure or a diagnosis of UTI, or, it's like caregivers, when asked, well, what problems does he or she have? Medical problems. Use any information you can get hands on. Any information will count. Just, bring your notes, bring whatever you got, and tell us what are the conditions. This one, yes, no. This one, yes, no. This one, yes, no. Okay, well, they did fairly well, but they didn't do well enough. Now we can describe care partners. How stressed were they? Well, 40% had moderate to severe stress. 30% were depressed or anxious. 20% had fair or poor self-rated health, and 20% screened positive for cognitive impairment on a mini-cog. Health-related social needs, we didn't do very well with our measures there. We used a very simple measure, but 41% of caregivers said they had trouble paying for basic needs. This was at University Hospital. So how about the care delivery framework? Well, UW had no formal dementia care pathway in the system. What we found in this group is that people were not being referred to palliative care, to care coordination, to any kind of specialty geriatric care or cognitive disorder services. They weren't going there. They weren't being sent there. And 80% of the medical records had no dementia-related recommendations or care partner coaching done. 80%. So, and 30% of the care partners said they never were told that the patient had dementia. That's not surprising. We know this. And 40% couldn't recall ever being asked about their care preferences. Okay, and so that's how we use the 6 domains to evaluate patients, to evaluate caregivers, and to organize care. The model is designed to create a dyadic snapshot and to identify those problems that are most in need of care now by looking at this systematically through the domains. We published a paper about this using this way. and we have a chapter coming. But where we are today is, I'm glad Alyssa left, because when I showed her this slide, I wanted to use it to say what we have to do is avoid being monkey medicine providers. She thought it would be so offensive if I said that I think that's probably right, but I count myself in there. What are monkey doctors? Well, we are all monkey doctors, right? And we're even more so in the sense that as we gain evidence base, we have much simpler ways to make very tough decisions. That's what algorithms are good for. And so, but the way we're using them now, while our patients wait in the background wondering what the heck we're doing, here we are all in front of our own laptop doing our own thing and not really playing with each other. And again, not a surprise, but probably a different image than the one you might have had before about what happens when we divide care so in such specialized ways that we don't really see the whole person anymore, because that's, there they are in the background. Nobody's even looking at them. And so could a unifying scorecard bring us together? If we agree no crisis care is our goal, then how do we develop some kind of a scorecard or something like that could get us working toward it? It would be a meaningful measure of dyadic complexity for healthcare, right? Integrates all these things and has potential value for both including all the relevant care disciplines, but also looking at outcomes in a different way, overall dementia care outcomes differently. And it can be used as a population stratifier that is accessible at the point of care under ideal circumstances. Could we do it? Well, we tried to do it. We tried to fuss with the data and see if we couldn't create some kind of a unified scorecard, kind of a stratification by total dyadic complexity. And it wasn't very effective. It was, a kind of beginner's effort to think about it. And but I kept on thinking about it, and I'm still thinking about it today, which is why I'm talking to you about it. And I think that this is a job for AI. This is AI at its best. I mean, I know that we all have our feelings about the place of AI in different environments, but it's here to stay. And something like this, AI is the master of complex modeling. And that's what I want to promote here today as a way to begin to conceptualize and then enact a no crisis care plan for dementia. So this is just for your reference, a wonderful article on AI and healthcare delivery. What's it good for and how are we using it now? It's good for a lot of different things, and a lot of those things would matter in dementia too. And then finally, this is what it would be like if we stopped looking at our laptops in our little silos and all looked out at the same universe and said, what can we do together? And that's the question I leave you with, is what can we do together to arrive at no crisis care? And I thank you.
Wonderful. And people are thinking about, we can take a couple questions. I just wanted to present the, plaque. It's
A plaque?
And it says to educators who affect eternity. So teachers.
Oh my God. What a load. Oh, isn't that kind? Oh, that's so nice.
Hopefully it
Thank
won't
you
make
so
your
much.
carry on too heavy.
Thank you so much. That's just
Absolutely.
lovely.
Thank
Right.
you so much for visiting us.
Thanks.
Yeah. A mic.
Well, a tangled talk at that. Yeah. Mm-hmm. Mm-hmm. Yeah. Well, the way I think about almost anything is, what is the value of doing something differently, right? So if you have somebody who doesn't want to talk about it, then what is the value of sitting them down and handcuffing them to the chair and saying, look at this, look at your performance on this test? I mean, is there any value in that? Although you would never do that, obviously, but I can be a drama queen, and I get my chance when I'm standing here by a microphone to be a little dramatic. The thing that I would say about that is, I like to lie. I like to say, we all get older, and sometimes people need help with stuff they didn't need help with before. And let's take a look at that. Are there any things that you might need help with? Or does your wife or husband or daughter or son or anyone think that are they trying to help you do something and you're not sure if you need their help? So I really just switch it into a different dialogue about the consequences of cognitive impairment bypassing the labeling function. I'm quite convinced that there's a sizable proportion of patients with dementia in primary care practices everywhere whose doctors know that they have dementia, but who have never made the diagnosis. That's one of the things that Alyssa's project is going to try to get at through an interview mechanism, is, do you ever know that somebody has dementia, but you don't make the diagnosis and you don't talk about it as such? Because there's a lot of that out there. And so I want us to distinguish between knowing that someone has cognitive impairment and actually making a diagnosis, which is a social act, a social and interpersonal act as much as it is a medical act. And so perhaps what we need is just a different designation for that type of person who has obvious signs of cognitive impairment, and this is what they are, but they do not want to talk about it. They may not recognize it, but they are willing to talk about the fact that they're not quite as good with the bills anymore, and yes, their wife can do them. And so it's all about how do we make life better and avoid crisis. So there's too much crisis, I think, that we've fomented around dementia diagnosis, that by teaching people that you can die of dementia, we've tried to teach people that everybody dies if they have dementia. They all die of dementia, and mostly they don't. And so I think we need to kind of step away from that catastrophic narrative and work much more in the line of functionality. Would that work in that circumstance, do you think? In the circumstance you're mentioning? Yeah. So I once told my department chair at UW that I didn't always disclose an Alzheimer's diagnosis with a patient. He was shocked and thought that I was really practicing bad medicine. And I explained why I didn't always do it. It's because I didn't think there was always purpose in the labeling process. There's great purpose in the knowing that I know, and that I convey that knowledge to people who care for the person involved, but that conveying that knowledge as a label to a person who is impaired may not be of benefit to them. So I think that's clinical medicine. And I think we need a category for it. It's the knowing, but not labeling. Because when you frame it that way, we get out of the idea of rates of diagnosis are far too low. Well, far too low for what? That's what we should be asking. What is the value of having the diagnoses? There are values, but we need to articulate them. Yes.
Building on that scenario, what is kind of like the ethical responsibility when someone still has a job or something where their impairment might affect well-being?
Yeah. Well, I mean, the most obvious case that probably we all have thought about a little bit is the impaired physician, right? The older doctor who is showing signs of impairment, and the proposal that all doctors over a certain age all professors over a certain age, all, anybody in a position of potential authority over anyone ought to be tested for cognitive impairment at a certain time. And that, do you have opinions about this? What is the ethical responsibility? I mean, embedded in your question is probably an assumed answer. And what is your answer?
I guess I'm not sure I have one, but I guess I'm thinking of like that there's so many more crises that can evolve other than them ending up, like
Yes.
someone's small business that they've built for 30 years.
Yeah.
Entirely simple. And how do you weigh that sort of importance in someone's life?
Right.
And their responsibility for their employees, et cetera. Like, and how does that definition of crisis?
Well, that definition of crisis would fall under the health-related social needs category of the 6 domains, probably, right? Because there is a health condition and there is a social need, and that social need is not for food, but it is for help in making decisions about the business. That's a social act, right? In part. So I think that, that therein lies the relational aspect of dementia care, that one can enact a responsible path by having the responsible conversations over a period of time. Are you having any trouble with the books? But these are interview skills. It's all of this is based on interview. Yes, did you have a hand up? Yeah, stay, right, stay and thank you for your patience. Okay, all right, thank you.